So, hello students, this is going to be the ENT revision of last few years NEET examination questions. It's last few days for your NEET-PG 2021. Hope you are doing well. You just go through this video, you will have some idea about how last few years the questions are being asked in ENT. So, I'll start with the class. First, I'll explain the trend how ENT has been asked for the past few NEET examinations. See, we are having ear, nose, throat. So out of which ear is the most high important topic. Out of 52 questions, 23 has been asked from ear. So comparatively, ear is the important topic. But wait, but the thing is, there are more than 10 topics to study in ear. Fine. Whereas in nose and pharynx, you could study only 2 topics and score higher. In throat, you could study only 3 topics and score higher. Rest other topics you can study, but the high yield topics are only 2 in rhinology and 3 in laryngology. So it's going to be a win-win situation for you to score more than 8 marks, 8 questions in ENT NEET examination. You need to study otology, because otology, we can't say that some topic is very important, some topic is not important. The distribution of questions, see here in otology, the distribution of questions are sporadic. You can't pick an important topic, so sure this topic will be asked in next year. We can't say that. For example, if a question from Minas has been asked this year, next 3 years it will not be asked. So the trend will change. So the sporadic distribution of questions in otology makes it a mandatory that you should study all the important topics in otology. For this is the proof of that. In other section, we are having 11 questions, whereas I try to pick the other topics. For example, if I had picked ear discharge as the topic, 5 questions are asked, means combined AIMS and NEET, I have given these numbers. Fine. Ear discharge means I can't say that a question is asked from serous otitis media. Not like that. Out of last 5 years, only once or twice serous otitis media has been asked. So this ear discharge means it's a bigger topic. It's not like a smaller topic, so you can study. It's a high yield topic, not like that. A bigger topic. In that bigger topic, including AIMS and NEET, we are only asked 5 questions. So what I'm trying to say now, in otology, you try to read almost all the topics. You revise all the topics. Any topic can be asked as a question. Okay. So still, I have picked ear discharge topic. So ear discharge means my approach is quite different. So I'll not deal with diseases. I'll go in a random conceptual manner. First, I'll start with a pharyngeal arch kind of introduction. So pharyngeal arches is much needed for development of middle ear and external ear kind of things. So I'll start with the pharyngeal arches, then the symptomatology based approach. So I'll go like this. So based on my symptomatology based approach, ear discharge is the symptom I have taken. So if ear discharge is the symptom, what are all the findings that you should look into the patient? What are the history that you should look into the patient? What are the possible diagnoses that you could come across in a patient with ear discharge? It could be any ear discharge, mucopurulent, serous, could be bloody discharge, whatever it may be. So I have taken that as my first topic for discussion. So see here, a 4-year-old child coming with complaints of fever and ear pain. On examination, there was congestion with bulging of tympanic membrane. Fine. So this is the question. First, the age. So in pediatric age group, fever and ear pain. So it should be an acute. It should be an acute condition. Then there is bulging of tympanic membrane. So this clearly states that there is only bulging, but there is no perforation. See, in chronic otitis media, there should be perforation. In tubotympanic type, otherwise called active mucosal type. So why I'm telling you this, because if the question carries the tympanic membrane is intact, it means that it is not chronic otitis media tubotympanic type. In Attico-Untitled type, there is unsafe type, otherwise called active squamous cell type. There may be intact tympanic membrane, but you will be having obvious findings in the pars flaccida. So tympanic membrane has two parts, pars tensa. So this is the pars tensa. So this will be the pars flaccida. Fine. So if it is an active squamous type of disease, there will be disease of the pars flaccida. Fine. So with this, we can clearly rule out the chronic otitis media. Now what we are left with, it could be an acute middle ear disease, that is acute suppurative otitis media, or it could be other middle ear disease like serous otitis media, because the age group is ideal for that. Then then we should rule out the other condition, and based on the option we should come out with the diagnosis. Myringotomy with antibiotics. Myringotomy is nothing but making a hole at the tympanic membrane to drain out the pus. So myringotomy is nothing but making a hole at the tympanic membrane to drain out the pus. So it will be done in a case of serous otitis media. Fine. So myringotomy with just draining out pus and then antibiotics, serous otitis media. Again, myringotomy with grommet insertion is again done for serous otitis media. Oral antibiotics and decongestants. For example, if this is the first time that individual is having a middle ear disease, then you can only give oral antibiotics. Why decongestant? Decongestant is nothing but, see, this is our middle ear. Our middle ear is connected with our nasopharynx. Fine. So if there is an upper respiratory infection, then there will be infection spreading to the middle ear from the nasopharynx via this eustachian tube. So if there is an nasal pathology, then it can enter into nasopharynx, then it can reach the middle ear via the eustachian tube. That's why decongestions are nothing but to reduce the inflammation of nose. So if we reduce the inflammation of the nose, then it could actually reduce the inflammation around the eustachian tube, then it can reduce the disease. So this is done for mainly acute suppurative otitis media. Again, antihistamines and decongestants only. See, the oral antibiotics is for treating the ear condition. Decongestants are used for treating the nose condition. In the option D, only antihistamines and decongestion. These are the treatment done for allergic rhinitis or any allergic sinusitis. So why this option is important? Because this option completely states or gives opinion about the nose pathology. So only if there is a nose pathology, then we can go with this treatment. If there is an ear pathology, you should treat the cause, that is the nose. Then you should also treat the effect, that is acute suppurative otitis media. So the answer for this question is C. So why I am telling you this? Because so there are diseases associated with middle ear, mainly 3. So I tell you this with a brilliant story. For example, your house, you left it out, you went for a vacation. The dogs are watching your house, guarding your house. If your house is having hefty amounts of gold, jewels, cash, some thieves will plan to thief your jewels. knowing that you are not in the town. If the thieves plan one day, so whom the thieves will fight it out? Against the dogs. The thieves should fight with the dogs. Then only the thieves can enter into our house. Then they can steal all the valuable items. Why I am telling you this? Because, for example, you just remember where the thief will come into our house, that is our into our fence, through the septic tank opening. There will be septic tank opening. No, the thief will be coming out of the septic tank opening. Then the thief should fight with the dogs. The dogs are like the inflammatory mediators. The thieves are like the microorganisms. There will be an intense fight between the thief and microorganism. Microorganism and inflammatory mediators. That is thief and dogs. Who wins that battle will determine the outcome of the disease. If the dogs wins the battle, then the infection is evaded out. The microbes are evaded out. Then it shows acute suppurative otitis media. The patient has resolution phase. That is, he has recovered from that acute inflammation. If the thief wins the battle, he kills the dog and he entered into the house, and he could easily rob all the valuable items and can cause complications. So acute suppurative otitis media has been breached. It has become chronic suppurative otitis media. So this suppurative word has been used before. Now it is not been used. So if the question carries such word, then it don't complain. It can come as suppuration or not. It can come as chronic suppurative otitis media, or it can also come as chronic otitis media, because the suppuration word is not specific for middle ear disease, can come in any disease. So that's why the suppurative term has been removed. So acute otitis media, that is the thief coming into the house, wins the battle, enters in the house, become chronic otitis media. So where comes the serious otitis media? Serious otitis media, I have told you, no. If our dog barks without the entry of the thieves, for example, if the dog's barking without thieves in the presence of the window screen moving for air, if such situation occurs, there is no infection. No infection, no pus, only serous discharge. If there is only serous discharge in the middle ear, then it is serious otitis media. As I already told you, if this is the middle ear, if there is some structures that is blocking the eustachian tube opening, then there will be defective pressure maintenance between the middle ear and nasopharynx. The function of the eustachian tube is maintain the pressure between the middle ear and the nasopharynx. If that function is not proper due to the blocking of the eustachian tube opening, then it can result in serious otitis media. See here, there is no infection. That is only mechanical obstruction. So which does it means that there will never be an infection? It can be an infection later days, but initially there will be only suppuration. Initially there will be only serious discharge. The most common cause for serious otitis media is adenoid hypertrophy and then carcinoma nasopharynx. So these are the swellings that comes in the nasopharynx. So if such conditions occurs, then there could be serious discharge inside the middle ear. There is no pus. In acute otitis media, if the dog wins the battle, the thief evades out, that is microbes evades out, then it is acute otitis media. It has resolved with antibiotics. Fine. If chronic otitis media, the dog is dead, the thief has entered into the house to create complication. So I hope you are very clear with my story. So now your role is the treatment of serious otitis media is myringotomy with grommet insertion. The treatment of acute otitis media is oral antibiotics. The treatment of chronic otitis media based on severity, we can start with oral antibiotics. If it doesn't heals on its own, then you should do surgery. The surgery is cortical mastoidectomy with tympanoplasty. This is for, that is, mucosal type, which means safe type, or tubotympanic type. If the disease has become unsafe type, that is artichoantral type, we should do modified radical mastoidectomy. Fine. Okay. We have seen about 3 otitis media. This otitis media is being frequently asked for the past 3 years. 2 times this question has been asked. Which of the following is not a which of tubercular otitis media? The TB can affect the middle ear. It can cause many features. So, not a feature. It can cause pale granulation. It can cause multiple perforation. It can cause foul smelling ear discharge, but not earring. So, painless, pale discharge, that is foul smelling, comes with multiple perforations. So pale discharge or pale granulations. So these are the findings of the tuberculous otitis media. This question has been asked in NEET 2020, also been asked in NEET 2019. So please be aware, it may even be asked. So nothing, that it's a factual question, nothing to worry. This is the typical depiction of tuberculous otitis media. So what should be the treatment? Of course, you should do debridement of the disease followed by ATT, anti-tubercular therapy. Fine. So these are the things has been asked in ear discharge kind of MCQ. This is the pattern for the past 3 or 4 years. Then this kind of questions, that is recent advanced questions like cochlear implant. Hearing aid is a past advance, it's not recent advance. Cochlear implant, brainstem implant, middle ear implant. These are the questions being asked are potential MCQs for forthcoming years. So you should pay attention for these MCQs. For example, what is the electrode of cochlear implant? Where is the electrode of cochlear implant placed? So the options are scala vestibuli, media, tympani, and then oval window. The answer is scala tympani. See here shows the ear. In ear, we should approach, this is the ear canal. So behind the ear canal, you should go and you should approach the mastoid air cell. You could find the facial recess. See, this is facial nerve. This is chorda tympani. Here you will be having facial recess. So this one you could do behind the ear, that is approach the mastoid air cell system. You could reach the facial recess through the facial recess. For example, if you want to look into something in a bedroom, it's not mandatory that you should come through your door. So entering the ear canal, then going the middle ear, then reaching the mastoid air system is like the routine way. If you could see through the window, you could easily peer into what is happening in your bedroom. So this kind of thing is like watching your middle ear through a window-like structure, that is facial recess. If you could see the round window through this, then you could insert the electrodes. Electrodes are electrical stimulating setup being installed in the ear of that infant. So these electrodes will be inserted into the Round window is nothing but, see, the structure that is superior is scala vestibuli, middle is media, lower is tympani. Fine. So you could insert the electrode through the round window into the scala tympani. So what are the other questions that they could ask in cochlear implant? The candidacy is less than 6 years. So if the surgery is being done for less than 6 years, then the child could have proper auditory development. So that one you should keep it in mind. Then you should be having proper speech therapy for at least 2 years. For that child to pick up with the lost time when she or he were deaf mute. So the important and most common indication is bilateral sensory neural hearing loss. Fine. So I hope you are fine. Cochlear implant is latest advanced device. We are inserting directly into the inner ear. For that child which doesn't have any hearing, doesn't have any sensory neural hearing. So in that child, we are using it as a device to pick up with the hearing and auditory development. Fine. Okay. This question is very important. If there is a defective inner ear, then we should insert an electrode. If there is a defective inner ear to pick up the electrode, there is no cochlea, there is defective development of the inner ear itself. Even if the electrode is inserted, it will not pick up the electric stimulus and send it into the brain. In such cases, we should do brainstem implant. This is actually an AIMS question. I have inserted this question to make you understand the difference between cochlear implant and brainstem implant. Now, a 2-year-old child planned for brainstem implant. All are indications for brainstem implant except so. Brainstem implant means the inner ear should be completely defective. Bilateral neurofibromatosis, absent auditory nerves, Mondinus deformity, absent cochlea. So that point, the answer you know very well is, so in absent cochlea, you should definitely do middle ear implant. Absent auditory nerves, the nerves are not ready to pick up the electrodes. So you should definitely do the brainstem implant. So the query is between the bilateral neurofibromatosis and Mondinus deformity. So we'll see what is neurofibromatosis. You have heard of this neurogrenous syndrome in your pediatrics or dermatology, but neurofibromatosis, if it is bilateral, it can cause bilateral vestibular schwannoma. So what is bilateral vestibular schwannoma? It's a tumor of 8th nerve. It can cause compression of cochlear nerve, causing retrocochlear deafness. So look, retrocochlear deafness, bilateral. So if you are able, if you can try to insert cochlear implant, then again it will not be possible in bilateral neurofibromatosis. Again, in bilateral neurofibromatosis, you should do brainstem implant, not this one. Mondinus deformity. These many deformities are there. Michael's deformity, Alexander deformity, Bing-Sieberman deformity. So Mondinus deformity. Many deformities are there. If you find it as confused or difficult, you just remember it starts with M, ends with M. First one is Mike Hell, end with Mondine. There are many evils found around you. Some evils are like hell. Some evils are like your friend. It will be sitting right next to you in your dining table, dine. So, but all are evil. The evil severity is varies from one devil to another devil. One devil is like hell, that is Michael. There is no inner ear. There is no membranous labyrinth. There is no bony labyrinth. So there will be no inner ear. So it will be like hell. The child will feel like hell. In Michael's deformity, then you can go for middle ear implant. Sorry, you can go for brainstem implant. So in Michael deformity, no inner ear. So we can go for brainstem implant. In Montanus deformity, there is only defective turns of cochlea. So normally the cochlea should be having 2, 3, 4th turn. If the turn is not proper, there is only 1.5 turns are present, means that it is called Montanus deformity. In Montanus deformity, the cochlea is defective, then it is not adequate to hear the normal sounds. Then we could insert cochlear implant electrodes into the inner ear that will help the child to improve hearing. So Montanus deformity is an indication for cochlear implant. Michael's deformity is complete contraindication for cochlear implant, whereas you can do brainstem implant for Michael's deformity. These are the futuristic questions. Brainstem implant, they were asked to any extent. So cochlear implant, brainstem implant, you should remember. What is middle ear implant? It's nothing but the patient having conductive hearing loss due to ossicle defects. So if ossicle is fixed, if ossicle is not properly conducting, then we could fix this middle ear implant into the ossicles. It will increase the vibration of the ossicles. See, the hearing aid, so the hearing aid is placed over here. So it amplifies the sound. For example, the sound is received, it acts like an amplifier. So the sound amplification may be 10 times or 20 times. It just amplifies the sound so that we could hear better. That is the role of hearing aid. But in middle ear implant, we could fix the implant into any of the ossicles. It will increase the vibration of the ossicles. If the vibration of the ossicles are increased, then it increases the conductive component of the hearing. So again, it is not used for sensory neural hearing loss. It is used for conducting hearing loss due to some ossicle pathology. That's the difference between hearing aid and middle ear implant. So these are the futuristic MCQs. Then MCQs that you could expect in this NEET. Rhinology, as I told you, there are 1, 2 or 3 high yield topics. If you are thorough with that high yield topic, you could definitely score in this NEET exam. In rhinology, I have already discussed the sinusitis component, mucormycosis. Again, it can be a potential MCQs. It has already been discussed by me in previous video. You can go through and check it. Now I'm going to tell you some different topic. That topic is again important. It's been repeatedly asked for the past 3 years. So see the trend of topics in rhinology. Epistaxis is much important. So you should be thorough with the blood supply of the medial wall of the nose, lateral wall of the nose, then the blood vessels from the internal carotid artery, external carotid artery. So you should be very clear with that. What are the treatment for the epistaxis? Anti-epistaxis, post-epistaxis, nasal packing. So it is very easy topic, but very much important topic. So epistaxis, you can study on your own. Now I'm going to tell about anatomy of the nose and radiology. This one carries 5 questions for the past 3-4 years. For 5 years, 5 questions has been asked, but the topic is very simple. The topic is very much primitive. So the thing you should understand over here is Osteomyel Complex. So osteomyel complex is nothing but a combination of all the middle meatus. So for example, this is the middle meatus. You are having middle turbinate, you are having uncinate process, so in this osteomyel complex, almost all of the paranasal sinuses will come undrained. Okay, so except posterior ethmoidal sinus, and sphenoid sinus. So except these two sinuses, you just remember this, except these two sinuses, all the paranasal sinuses like anterior ethmoid, middle ethmoid, frontal, maxilla, all these will come and drain into this middle meatus. This middle meatus will form a three-dimensional structure called osteomyel complex. So this osteomyel complex should be very clear. Again, you should be clear with that. This is the important anatomy of lateral wall of the nose. Now I am going to discuss the important radiological aspect of nose. So radiology of ENT, the main thing is first ear, only 2 or 3 views are important. In nose, only 2 views are important. How and which views will show the sinuses better? So you are concerned mainly with the sinuses, not with other structures in X-rays. So the question is, what is occipitomental view with open mouth? Also, this is a NEET 2020 question. So open mouth is also known as Waters view. For example, if the option is not given, if the option Peary's view is given, again it is a correct answer. So it is also known as Peary's view. So Waters view is nothing but occipitomental view. You just remember it as, you be any religion, you would have seen Shiva, right? Lord Shiva. So Lord Shiva, he will be having some hair, a bigger hair. Water will be coming from his head, right? You just imagine that for Shiva, water is coming from the head, falling to the mandible. So occipitomental. So that's explains you the occipitomental view. Waters view means occipital, water coming from occipit of Lord Shiva to the mentum, that is mandible of Lord Shiva. So you just remember it as occipitomental view. Then Townie's view, Law's view, Stenvo's view, all these views are seen in ear. Okay, that we will discuss with ear radiology. So in nose, what is view? What are the others view? So if open mouth is not, if we don't open the mouth in occipitomental view, that is Waters view. If you open the mouth, that is Waters view, open mouth view. The Waters view, open mouth view is also called as Peary's view. Okay, what is the other view? We have missed this. Caldwell view. This is frontonasal view. Okay, this is frontonasal view. Okay, let's jump into this. This is then occipitomental view with mouth open, otherwise called Peary's view. See, we could see the maxillary sinus. We could see the frontal sinus. Okay. Okay, this one, it is not very clear, the sphenoid sinus. The mouth opening is not adequate. If the mouth opening is big enough, you could see the sphenoid sinus over here. This is not an adequate mouth opening. The sphenoid sinus is not visible perfectly. Here we could see a perfect sphenoid sinus in an open mouth view. Then you could see ethmoid sinus over here. So which sinus is better viewed? Maxillary sinus is the best sinus viewed in, because you are viewing from the front, right? Then the maxillary sinus is the best sinus that is visualized by our Waters view. Fine. What is the best structure that is visualized via Caldwell's view. What I told you, the Caldwell's view is a frontonasal view. So easily the frontal sinus is best viewed in Caldwell's view. In Caldwell's view, we could see frontal, ethmoid, and maxillary, but we could not see sphenoid sinus to that extent. But in Waters view, we can see all four sinuses. Okay, fine. Again, Waters view is best to visualize which of the following? The answer is maxillary sinus. So that's easy, right? So, I have already dealt the sinus anatomy and diseases detailed previous video. This is just to brush up on the radiological aspect of rhinology. Later on of sinus also carries many number of questions, but some questions are not asked recently, but again it's an important topic. In AIMS it has been repeatedly asked. In NEET you could expect this time from lateral wall of the nose or from the diseases of the parental sinuses. So this one is not covered previously, that's why I covered this now. Now we can enter into laryngology. Laryngology, you don't have to panic at laryngology. I too have thought that, see, the anatomy of laryngology is very much difficult. There may be too much questions that may be asked from anatomy of larynx, but that's not the case. Anatomy of larynx is not being asked in recent examinations for last 5 years. Anatomy of larynx is not much focused. What is conus elasticus? What is quadrangular membrane? What is preepiglottic space? What is paraglottic space? Many questions are there. You should keep on memorizing all those stuff. But you just have a look at that. You just compare preepiglottic space and paraglottic space. You just compare conus elasticus and quadrangular membrane. What are intrinsic membranes? What are extrinsic membranes? But what is much important is malignancy of larynx and malignancy of head and neck. Then neck space infection, vocal cord disease. These are the three important topics, high yield topics that you could bet upon. These are short questions being. If you study these three topics, you could easily answer one or two questions from laryngology. Fine. You can enter laryngology. The first question is: a 9-year-old boy comes with complaints of right ear pain, difficulty in opening the mouth, painful swallowing, and fever. The oral cavity examination is given in the picture. No facial puffiness noted. Fine. So see, in this open mouth view, open mouth examination, we could see normal tonsillar fossa. We could see bulged tonsillar fossa. This is unilateral tonsillar enlargement. If this 9-year-old boy is having tonsillitis, then it should be bilateral. So tonsillitis, you never reckon it should be bilateral. If it is unilateral, there is something else. It could be an infection, or even if it could be a malignancy. But chronic tonsillitis will come to two sides. If you are doing tonsillectomy, you should remove both tonsils, never one side. Fine. So this is not tonsillitis, but the child is having right ear pain. There comes the referred ear pain. This will be discussed detailedly in ear topic itself. What is referred otology? What are the nerves that are concerned with referred otology? I'll tell in just in pharynx, 9th cranial nerve also supplies pharynx and ear. So if there is a problem in the pharynx, it can be referred to the ear, that is mainly middle ear. It is supplied by Jacobson part of glossopharyngeal nerve. Then larynx. Vagus nerve supplies larynx as well as ear, Arnold branch of vagus. So referred pain from larynx can be referred to the ear. Then 5th cranial nerve, trigeminal nerve. So there is a branch for mandibular nerve over the face and also auriculotemporal nerve over the ear. So these are the possibilities that where you could get referred otology. See here, the pharynx is affected, the glossopharyngeal nerve is stimulated. So the right ear pain is nothing but referred otology due to disease of the pharynx affecting to their common dermatomal distribution. Fine. Difficulty in opening the mouth. It is very toxic. Okay, very toxic. The patient is finding it very difficult. Fever is there. Acute history is there. So what could be the cause? So pharyngitis. Pharyngitis is nothing but only posterior pharyngeal wall congestion will be there. There will not be an abscess of the tonsil. Parotid abscess. No parotid disease is given in this picture. That is not the case. Basalt abscess. Basalt abscess is a complication. Chronic otitis media. So quinsy is otherwise called peritonsillar abscess. Fine. So why I have quoted this question? This is NEET 2020. See, the infection of the neck, deep neck spaces of the infection is much important. So I'll brush up on this. So I'll tell you again a story for this. Have you noted? Have you heard of forest fire? If one tree has caught fire, all the trees will be destroyed in seconds, right? That's how a forest fire works. That's how dreadful the forest fire is. If the same thing happens in our neck, for example, if the superficial part, that is the skin over here, has some skin infection, if there is no separation between the superficial compartment and deep compartment, and there is no separation between the internal carotid artery and the superficial compartment, any infection, even a small scratch, nail scratch, it can lead to an infection of the skin over the neck. It can enter into the internal carotid artery. It could absolutely cost you the life. So to prevent that, every compartment in the neck is separated by many fascias. So we are dividing the fascias into superficial and deep. See, I have made this. See, if there is no fascia is there, like this forest fire, it could enter into the vertebra or this trachea, esophagus, important structures. So it is being isolated and separated, compartmentalized with the help of fascia. This is the fascia, this is the fascia. So many important fascias are there. So we are dividing the fascias into superficial and deep. Superficial fascia is nothing but a fascia covering upon the platysma muscle only. It is not much. It is just covering the platysma, nothing more than that. Deep fascia. So what is this deep fascia? It is divided into three. Investing layer, then middle layer, deep. The middle layer is otherwise called pretracheal fascia. The deep is otherwise called prevertebral fascia. Investing in a deep fascia is much important. So it invests into many important structures. It covers sternocleidomastoid and trapezius, two muscles. It covers parotid gland and submandibular gland. So it attaches with all the bony landmarks of the head and neck region, like mandible, mastoid, scapula, clavicle, sternum. So all these areas, the investing layer of deep cervical fascia will get attached to itself. So that's why it invests so much. It can cover a wide range. See here, this red one I have quoted is the investing layer of deep cervical fascia that is covering upon the sternocleidomastoid and trapezius. Then it also covers the viscera. It also covers the many muscles. So this one that is covering over the thyroid gland. See, this is the thyroid gland. This is the pretracheal fascia. So this one covering over the vertebra, this is prevertebral fascia. See this one, it is middle of all these fascia. See here there is investing layer, here there is pretracheal layer, here there is prevertebral layer. All these layer in between, some structure, some space is there, means that space is carotid fascia. Carotid sheath. So it covers the vital and most important blood vessels like jugular vein, internal carotid artery, and vagus nerve. So why, if someone is being guarded by all the three layers, it will be very much protective, because that is the much important aspect of the neck. If these three goes damaged or destroyed, or if infection spread easily, then that's the end of our life, right? So that's why all these three layers will contribute to carotid sheath. Fine. So if you have some basic understanding, you can easily solve the MCQs of the deep neck space infection. So only three abscesses are much important. Retropharyngeal abscess behind the pharynx, retropharynx, parapharyngeal abscess parallel to, this is the pharynx, so parallel to the pharynx. Quinsy, other is called peritonsillar abscess. These three are very much important. So I'll give you some important gist points, which with each. Retropharyngeal abscess is nothing but, it could be divided into two, acute and chronic. So acute occurs in neck injury, chronic occurs in tuberculosis. Fine. Chronic can occur in adults, acute can occur in children. See here, there will be, this is the vertebra, this is the pharynx, there will be prevertebral shadow widening. Lateral X-ray neck. Prevertebral space widening, prevertebral shadow widening, that is seen in X-ray neck. So this is the main investigation aspect. If the question carries prevertebral shadow widening, you can go for retropharyngeal abscess. What is the treatment for retropharyngeal abscess? You should give higher end antibiotics. Should drain the abscess. Orally or cutaneously. So you can go through the mouth behind the, that is posterior pharyngeal wall. If you breach the posterior pharyngeal wall, you can enter the retropharyngeal abscess. But the thing is, no intubation is advised. If the anesthetist give intubation, if the anesthetist rupture the retropharyngeal abscess, it can cause aspiration pneumonitis. So usually intubation is not advised in retropharyngeal abscess. You could do it in local anesthesia through oral route, or you can even do it through cutaneous route. Cutaneous route is quite difficult because the swelling will not be prominent over the skin. Whereas in parapharyngeal abscess, the swelling will be prominent over the exterior, because the parapharyngeal abscess is divided into pre-stellate space in front of stellate process, post-stellate space behind the stellate process, which is very important. Means post-stellate process is much important. So post-stellate is very important. Post-stellate can cause 9, 10, and 11 cranial nerve palsy, sympathetic involvement, sympathetic plexus involvement also can occur. So post-stellate is much dreadful. Pre-stellate, it can cause only medial bulging of tonsillar fossa. This parapharyngeal abscess also you could try oral route, but comparatively external route is much easier and simpler than the oral route. If it is a pre-stellate disease, then you could try oral route, because it will be causing medial bulging of the tonsillar fossa. So pre-stellate you can try oral route, but post-stellate you should definitely try only the cutaneous route for draining the abscess. So drain the abscess plus antibiotics. So that completes our parapharyngeal abscess. So retropharyngeal abscess, parapharyngeal abscess, that Quinsy is nothing but peritonsillar abscess. So you should give antibiotics. Wait for 6 weeks for the abscess to settle. Then you can go for interval tonsillectomy. So that's the treatment for Quinsy. You can use Quinsy forceps. The Quinsy forceps will be sharp at the tip. It will be like this. So you could use that Quinsy forceps to prick over the tonsillar fossa. So I have covered this deep neck space infection part. This malignancy part, I should explain everything, oral cavity, oropharynx. So it itself will take at least 1 hour duration. I will cover entire neck malignancy, oral cavity, oropharynx, laryngopharynx, hypopharynx, nasopharynx entirely in one discussion. So, but it will take at least 1 hour. But the malignancy part, I now cover only the stridor part and tracheostomy. So stridor is nothing but noisy breathing that we could hear due to upper airway obstruction. The airway obstruction can be anywhere. The airway obstruction can be at the level of even epiglottis, at the level of even supraglottis, okay, at the level of even vocal cord, at the level of even trachea. So if the obstruction is at the level of glottis, then there is both inspiratory and expiratory component. Okay, if there is level obstruction at the level of supraglottis, only inspiratory stridor. Subglottis, only expiratory stridor. So if the problem is below the subglottis, much below the trachea, bronchus, then it is lung pathology. So that will not cause stridor, that will cause added lung sounds. If the question carries some added lung sound, you should not confuse it as stridor. It indirectly means that tracheostomy is not a treatment for those pathologies. If there is stridor, there is a documented sound pathology, and this pathology has been documented either supraglottis, glottis, subglottis, then only you can proceed for tracheostomy. If you don't follow this, you can end up complicating the patient, because tracheostomy is not the treatment for lower airway disease. It is a treatment for, it is a rescue treatment for upper airway disease, right? Okay, that inspiration is found in what is supraglottis, fine. Okay, which of the following is an indication for high tracheostomy? See here, if you are planning for laryngectomy, for example, in laryngectomy, this one is cricoid cartilage, this one is trachea. So you will be removing the entire larynx like this. Okay, if the tracheostomy is done at the first ring, that is first tracheal ring, then we could remove this also along with the laryngectomy specimen. If you do a low tracheostomy at this one is 3 or 4, this will not cover the stoma site. That is again that can again be a reason for recurrence. So that is not advisable. The tracheostomy site should be included into the specimen of the laryngectomy, that is high tracheostomy. If the tracheostomy is done at the level of tracheal ring 1, then it is high tracheostomy. 2, 3, 4, then it is normal or normal tracheostomy. Sometimes there can even be a low tracheostomy done in cases of some thyroid malignancy. The thyroid malignancy can entirely occupy the trachea. You should somehow find the airway to salvage the patient. For that, we can do low tracheostomy. But high tracheostomy can be done for laryngectomy. The suspicion of the laryngeal carcinoma, planned for surgery later. So that surgery specimen should include the tracheostomy site. In vocal cord palsy, we can do high tracheostomy. We can do normal tracheostomy. That is 2, 3, 4 level. That is, I am telling about not T2. This is tracheal level. Second tracheal ring, third tracheal ring, fourth tracheal ring. Then tracheomalacia, we can do normal tracheostomy. Foreign body obstructions are at the level of glottis. So we should again do lower only. That is 2, 3, 4 level. So that is, so see here, this is the normal tracheostomy. If you are planning for malignancy, you should do at the higher level. Okay, this normal tracheostomy site for between the second and third tracheal, that is between second and third tracheal ring, the tracheostomy is being done, stoma is being created. Okay, fine. Okay. Again, this forms the important thing. There are only 4 diseases of the vocal cord. There is much being asked repeatedly. So identification of the vocal cord given in the image. So this is like papular, pale, warty lesion. So if there is a wart, in the vocal cord, then it is vocal cord papilloma. If it is a growth glottis, then it should be some proliferative lesion. So that is not the case here. So again, malignancy is being ruled out. Tracheomalacia. Tracheomalacia is nothing but enlargement of the tracheal ring. So there is no growth like thing in tracheomalacia. So the question is actually easy. So other three options are very easy to eliminate. So what are the vocal cord disorders? Structural vocal cord disorders that will be repeatedly asked. See, this is vocal cord nodule found at the junction of anterior 1/3 and posterior 2/3. Why? This is the area that will be most probably in contact with each other while production of speech. While you are speaking, the first area that comes in contact is the junction of anterior 1/3 and posterior 2/3. The last area that separates is this area. So it has most contact compared to other areas. So that area will be the prone for vocal cord nodule. So vocal cord nodule that causes vocal abuse. That is, you are not using the voice properly. If you screaming, if you are teacher by profession, you are keep on shouting, then your vocal cord will not tolerate. There will be some insult to the vocal cord tissues that causes vocal cord nodule. This vocal cord nodule treatment is voice therapy. You advise the patient not to shout. You give voice rest for at least 2 months. Then it can heal on its own. Surgery is mostly 90% surgery is not the treatment for vocal cord nodule. If the patient is not, if there is so much recurrent to this condition, then you can go for surgery. So this completes the vocal cord nodule. If there is a unilateral polypoidal mass, then it is vocal cord polyp. So here there is allergic asthmatic patient can have the vocal cord polyp. All these vocal cord disorders will be having hoarseness of voice. Right? So vocal cord polyp is nothing but it will not heal voice therapy. So you should do micro-laryngeal excision. So it is nothing but removal of the lesion with microscope. Okay. So microscope, there are microscope that you can use to view inside your vocal cords better. So micro-laryngeal excision is the treatment for vocal cord polyp. Then this is the Reinke's edema. See, so this is almost a grade 3 Reinke's edema. That is been repeatedly asked in MCQs. So the cause is hypothyroidism and smoking. Fine. So in this case, if there's grade 3 means, again we should do a micro-laryngeal excision to drain the fluid and then treat the cause. If there is hypothyroidism, you treat the thyroid status. If the patient is having smoking personal habit, ask the patient to stop smoking. So it occurs at the superficial lamina propria. Lamina propria has 3. Lamina propria 1, 2, and 3. The superficial lamina propria layer is otherwise called Reinke's edema. Okay, Reinke's space. In that space, if the fluid accumulates, means then it causes Reinke's edema. Fine. Then the final one is vocal cord papilloma. So it occurs due to human papilloma virus. Okay. So mostly it can be due to 6 or 11. So in infants, it can cause juvenile recurrent papillomatosis. Okay. Juvenile onset recurrent papillomatosis. Okay. So this 6 and 11 are the main cause. In CA cervix, 16 and 18 are the main cause. In the oropharynx tumor, human papillomavirus can be the cause. Again, it is 16 and 18. 6 and 11 is juvenile onset recurrent papillomatosis. Okay. The treatment is again surgery. You can administer ribavirin as the antiviral agent. Okay, so all these can be done, also be done with CO2 laser also. Either you could remove it with just gold seal instruments, or you can use carbon dioxide laser for removal of the same. Fine. That ends the vocal cord disorders. See, it's very simple in nose and throat. If you study left wall of the nose, if you study sinuses and diseases, you could answer at least 2 questions. Larynx, vocal cord diseases, malignancy, deep neck space infection. These are the high yield topics that you should look upon while dealing with preparation or revision part of ENT. In year, if you focus on one topic, that the topic may not be asked in this exam. So you should study almost all the topics. Some important topics I have discussed in this video. So hope you got a better understanding about how to prepare for the high yield topics of the ENT. Better luck. You will do in a better manner. Come out with flying colors.